So participants, I hope you are still here and that it is interesting for you as for us here that are watching for this and moderate. And also I would now like to announce the final speaker, Dr. Shala Namak. Dr. Shala Namak is coming from USA, from North Carolina, from Winston-Salem. Hello, Shala.
Hello. Hello.
Hello. Yes, and I would like to introduce Shala also in some warm words, because it was 2016 when I first met Shala Namak. Shala Namak is also specialist in obstetric and gynecology. She finished medical school and also fellowship in the Iraq, but then migrated to the United States. And then she also finished the family medicine fellowship, and she works in the University of Wake Forest Medical School in Winston-Salem. She is also a member of American Academy of Family Physicians and a member of Kybele organization. And this is the organization in the channel when two of us meet each other. Dr. Shala Namak visited Novi Sad, and she gave a wonderful lecture about electronic and external fetal monitoring, CTG traces, and made very interactive presentation. And this is how our collaboration started. And 3 years after that, we organized a wonderful also course, advanced life support in obstetrics course. And also many of colleagues from surrounding countries had the participation in this course. So you will see that Dr. Shala Namak prepared very also useful clinical lecture, and I don't want to take her more time than this. After this, we will have another quiz, and after the quiz, we will have the separation in the smaller groups. Stay with us, because in these smaller groups, we will be able to discuss some cases that you had in clinical practice that are maybe not clear to you, or you would like to share because it was not a good management, or you think it was very good management. And as a final part, we will close the webinar. Okay, so Dr. Namak, the floor is yours.
Thank you very much, Alexandra. Thank you. I am trying to read the slide. For some reason, my slides are very small, and I'm trying.
But we can see them. We can see them very well, and we can hear you.
Okay, good. I may close my camera so I can be close to it, and okay. I can. Yes, thank you.
No problem.
Very good. Okay, do you hear me well now?
Yes.
Okay. So I'm, well, I want to say hello to everyone. Thank you, Alexandra, for inviting me today for this wonderful gathering. And I learned a lot from Dr. Bulatovic and Dr. Dada. It was really great presentations ahead. My assignment was to talk about elevated blood pressure and what do we need to know when we have a patient. I'm not sure why it's not moved. Let me see if I'm trying to move my slides. So maybe if I click on it. Okay, so I have no conflict of interest. I just want to say, just like Dr. Dada said, that my presentation is really from the guidelines that we use here in the United States. So please, if there's something that you do not do, this is just information to share. Please, go back to your guidelines, and this will be maybe a conversation for you if something is different that we do here. Also about medication, it's really, we use what is available to us, but maybe in your countries you have more other medication that you use in your countries. So our objectives is to review the cases. We have obstetric emergency related to hypertensive disorder. It is like a hypertensive case, then maybe we have lady with seizure, and then other complication of hypertensive disease. So why is it important? It's important because hypertensive disorder is the leading cause of maternal and perinatal mortality globally. And I know that Dr. Data has also shared that 14% on his slide, was from hypertensive disease in pregnancy causing maternal mortality. So for preeclampsia, it complicates about 2 to 8% of pregnancies globally. We've seen increased risk about 6.7-fold in between 1980 and 2003, so definitely increasing. And also cost, it costs money to take care of these patients. There is antenatal testing, there is medication to be used, there's maybe more monitoring in the hospital and so forth. So for example, in the United States, it costs about $2.18 billion within the first 12 months postpartum in 2012, from 2012 data. Women cost about 1.03, and then infants at $1.15 billion dollars. Definition. So now let's learn about how do we define them. We have it could present as chronic hypertension or gestational hypertension, preeclampsia without severe feature, preeclampsia with severe feature, chronic hypertension with superimposed preeclampsia, HELP syndrome, and eclampsia. So let's start maybe with the chronic pre-existing hypertension, because that's something that started before pregnancy or early in pregnancy before 20 weeks gestation. So systolic blood pressure in this defined here as blood pressure equal or more than 140 millimeter mercury and or diastolic blood pressure more than 90 millimeter mercury. It's first diagnosed or present before pregnancy, or at least we need to have 2 occasions of elevated blood pressure 4 hours apart in less than 20 weeks gestation, and that persist at least 12 weeks postpartum. That's also considered chronic hypertension. So you may have a patient in antenatal care or prenatal care, elevated blood pressure now. I don't think I'm going to keep her for 4 hours because I need to go to the next patient and the next patient. So what I do, I may have her come back in 1 or 2 days to check another blood pressure and see if if it's elevated. So I can have 2 occasions for the diagnosis. In the setting of severe hypertension, you have the ranges of blood pressure is systolic of equal or more of 160 and diastolic equal or more of 110 millimeter mercury. But in this case, when you have severe hypertension, you don't need to wait for 4 hours or bring her back the next day. You need shorter time because this is a high range blood pressure and it needs immediate attention, timely treatment. The other possible progression of chronic hypertension in pregnancy, you could find it with superimposed preeclampsia or with superimposed preeclampsia with severe features. This is a slide which gonna differentiate and definition of gestational hypertension, preeclampsia without severe feature, and preeclampsia with severe feature. I'm not sure, do you see my arrow? Can you see my arrow? Anyway, so let's say if you had a patient come in to the triage or to your clinic and her blood pressure is equal or more than 140 and or 90 diastolic, and you measure it, like if you have ability in triage, let's say she comes to the hospital and you keep her, say, oh, this is elevated blood pressure, let me keep her for 4 hours, and you find that she has another blood pressure in this range, 4 hours apart, and she's more than 20 weeks gestation. And she have no, you look in her chart, there's no elevated blood pressure in the past. So the next step is you're going to go in and talk with the lady and ask her, do you have a headache? Do you have any pain? Any visual disturbance? You try to find if she's like feeling altered mental sensation, like ask her question, where are you? You know, some question to see if she's, you know, kind of her mental status evaluation, or if she's having shortness of breath and you listen to her lung, examine and hear some crackles, is that a pulmonary edema? So if these history, you have none of this, negative of this, and you have, if you have no lab abnormality, like you check for thrombocytopenia, a platelet less than 100,000, renal insufficiency, creatinine of 1.1, or double the creatinine of what they started with in pregnancy, or impaired liver function, like ALT, AST, twice the normal concentration. If you find she have no symptoms and no lab abnormality, and her blood pressure is still in the 140 and 90 range, then you check proteinuria to see if she has proteinuria or not. And that's what's going to differentiate between the preeclampsia without severe feature and gestational hypertension. For preeclampsia without severe feature, they have proteinuria, blood pressure range in the 140 over 90, below 160 over 110, and they have no symptoms, no lab abnormality. That's then preeclampsia without severe feature. If the patient have no proteinuria, blood pressure in the 140/90, and not severe range blood pressure, no lab abnormality, and no symptoms, then that's gestational hypertension. But if the patient, you monitor her and she start having blood pressure in the 160 over 110 diastolic, and if she's having symptoms or she's having abnormality in labs, then that's preeclampsia with severe features. Preeclampsia with severe features could present with or without proteinuria. They do not need to have proteinuria to be preeclampsia with severe features. Then we have other complications, which is like eclampsia and HELLP syndrome. Eclampsia, where a generalized seizure in a patient with preeclampsia that cannot be attributed to any other reasons of other causes of seizure disorder. HELLP syndrome, hemolysis, elevated liver enzyme, and low platelet. Hypertension may be absent, and HELLP in such cases is often considered a variant of preeclampsia. So we now have a case, a patient who is 19 years old, woman. She is the first primigravida. She's 33 weeks gestation, coming to the hospital saying, I have headache, and it's been going on for 6 hours. Her prenatal course has been unremarkable, and she denies any medical problem, no visual abnormality. Blood pressure is 140 over 90, and the baby heart rate is doing well, 140 beat per minute regular. You dip a urine protein in the clinic, and you see that her urine protein is 1+. So what is the most likely diagnosis? What would you do? Immediate next step? What is your priority lab test, and what is your management? And I'll check with you, Alexandra. How do you want us to do this? Do you want us to pause and see what they respond?
Yes, I think maybe you can repeat the question, and then we can ask them to put in the chat the answers. Okay,
great, great. So this is a 19-year-old primigravida. She's 33 weeks pregnancy. She came to the hospital with a complaint of headache for 6 hours. So you look at her prenatal course, you look at her charts, see, did she have any elevated pressures in the past? No, and she was quite healthy. You check her blood pressure is 140 over 90, but you ask her about vision change, she say no. and you check her heart rate is 140/90. Blood pressure 140/90. Baby heart rate is good, 140, and you check a urine dip, it's 1+ urine dip. Urine protein creatinine, if you do that in your clinic, we do spot urine protein creatinine ratio, it was 0.1, but if you do only the urine dip, it's 1+. So what would be your diagnosis, immediate next step, lab test you want to order, and what's your management plan?
Participants, be free to write in the chat. I think the first question is easy question. Shala, let's break the ice.
Okay, so I think this lady, since she have urine dip of 1+, remember we talked about gestational hypertension. What's the difference between gestational hypertension and preeclampsia without severe feature? The only difference is gestational hypertension does not have proteinuria, while preeclampsia without severe feature have the same parameters, except it has proteinuria. And neither of them have any lab abnormality or symptoms. This lady has headache, but you can't just take headache one time and say this is preeclampsia without severe feature with a blood pressure of 140/90. You gotta try some Tylenol and see if she say, oh, my headache is gone, then this is gestational hypertension. But if the headache remains, and then you got to monitor to see if this is preeclampsia without features or it is heading towards severe features. I hope that is clear. So let's move to the next slide, which is going to give us like the more in depth about the management. So when you have
Shala, can I interrupt you for a moment?
Yes.
So
yes.
We had one answer in the chat, and it answered like preeclampsia, and that she would admit her to the hospital and do the blood testing and creatinine, urea, and LDH. So
yeah.
can you just repeat to be clear of what would be the right answer?
Yeah, I think that is a very reasonable thing to do. These patients, you want to know, right? You want to declare them, and if you in your hospital or in your country, you observe them in the hospital. That's what you do. And in our practice here, if she is gestational hypertension, meaning, and I'm going to go back to the slide. I think if I go back to the slide, it helps. This slide, I think we need time to I would advise you to go back and look at this slide. Alexandra, can you see my arrow?
Yes, we can see the arrow.
Okay, so this is gestational hypertension. This is preeclampsia without severe features. They are the same, no symptoms, no symptoms, no lab abnormality, no lab abnormality, no severe hypertension, no severe range hypertension. The only thing they differ is proteinuria. No proteinuria with gestational hypertension, but proteinuria with preeclampsia without severe feature. Without severe feature. For preeclampsia with severe feature, you could have positive proteinuria or negative proteinuria. For proteinuria, but you have headache, you may have lab abnormality, you have the high blood pressure and one or more of lab or symptoms. If you come to proteinuria, protein creatinine ratio, if you use that test in your country or institute or hospital, it should be more equal or more than 0.3 to say preeclampsia, or you have a 24-hour urine protein of 300 or more, or you have a urine dipstick at least 2+ to say preeclampsia. But if you have 1+ or no proteinuria, then it's not considered, significant enough to call it preeclampsia. Is that helpful?
Yes, so we would not consider 1+ in dipstick like a proteinuria.
No, by definition, it is 2+. Yes, that is the correct, 2+ and more. By 1+ is not considered. I will monitor her definitely. We went out, we're not checking any protein in urine now. In our practice, we do not check urine protein unless we have elevated blood pressure. And that's when we check the proteinuria. Yeah. So
in this patient, would you
yes.
say that the differential diagnosis is gestational hypertension or preeclampsia?
So in this patient, if her headache recovered, if her headache is better and recovered, she's probably gestational hypertension. If her headache stayed and was getting worse or severe and she's having more symptoms, I would say though preeclampsia. But remember, preeclampsia should not be with symptoms. Then I keep a good eye on her blood pressure to see if it's going up to 160/90 to call her with severe features.
And of course, she's, we would say, juvenile pregnancy with 19. And she has this risk factor to develop the preeclampsia, isn't it?
Absolutely.
So at the moment, she's gestational hypertension, but with the predisposition to be the preeclampsia in some moment. And she's 33, so maybe in 2 weeks she will develop something more serious.
Yes, that is, I think, thank you, Alexandra. That is the best way I would say it. You said it exactly. Thank you.
Thank you.
Yeah. So how do we manage? Management of gestational hypertension and preeclampsia without severe features is almost the same. Blood count, platelets, serum, creatinine, LDH, AST, ALT, testing for proteinuria, uric acid, if you're unclear. If somebody in gestational hypertension, like they started, and you don't have like maybe antenatal testing before 20 weeks, or you don't know if she had high blood pressure before pregnancy, you may do a uric acid to see if she could be a chronic hypertension because it will increase with a superimposed preeclampsia. Also, you do a comprehensive clinical and maternal evaluation, do an ultrasound. You want to do estimated fetal weight, amniotic fluid, and you do fetal antepartum testing. And I know you could do a BPP or you could do non-stress test like twice a week, depending on what's available in your, in your clinics, in your hospital. Follow-up management is depending on gestational age because, you wanna get a baby. You don't want a baby to be in the NICU for months. You want to try your best to have a baby who comes out and maybe are ready to go with mother, or a baby who have less risk factors for being in the NICU and other complications, but you do your best. You can't compromise mother health for baby. So it's really a difficult balance, but you have to do your best to see where are we going. So definitely taking in consideration gestational age. So continued observation is appropriate for women with preterm fetus if she has gestational hypertension or preeclampsia without severe feature. We can continue to monitor these ladies. The decision to deliver must balance maternal and fetal risk. This is a slide which could give us a little, more clarity of who do we deliver, and who we could continue monitoring. So those who are equal or in gestational hypertension and preeclampsia without severe features. So any patient who is equal or more than 37 weeks gestation and she have gestational hypertension and or preeclampsia without severe feature, we will go for delivery. Because of the risk, like Alexandra, like you said, because of the risk of going to preeclampsia or preeclampsia with the severe features. If those are equal or more than 37 weeks, gestation and they have labor, they come in labor, or they have rupture of membranes, or they have the fetal strip is not reassuring, you know, they have deceleration of the baby, have fetal growth restriction on ultrasound and cannot wait, there's complication, or abruption placenta, those we will deliver. But those who are less than 37 weeks, we can do expectant management. It could be inpatient or outpatient depending on your institution, your country, your comfort zone. We do outpatient management, but we bring them more to the often. We offer the blood pressure at home. So at home, they check their blood pressure. We teach them how to do that. We tell them when to come in, if they have headache, if they have vision change, you know, upper belly pain, if they have shortness of breath or chest pain. No, so we give them instructions when to come in. So we also monitor the baby. We do twice weekly, the blood pressure at least twice weekly, or they can do it daily at home. Weekly lab tests, so we bring them back every week at least to do the blood test. We also can do NST twice a week, or we can do a BPP depending on what you have. Also ultrasound for growth, make sure they're growing. And then also you can do fetal umbilical Doppler, artery Doppler ultrasound for intrauterine growth restriction if present. If this is all no, then 37 weeks gestation, worsening maternal or fetal, we can continue monitoring until 37 weeks. So now there's 37 weeks, or if at any time during expectant management, there's worsening of maternal or fetal condition, labor or premature rupture of membrane, we don't wait, we deliver. So this is one slide about antenatal corticosteroid use for lung maturity. When we suspect increased risk of delivery within 7 days, and gestation is less than 34 weeks, we typically give prophylactic steroid injection. Example, pregnancy with complication of preterm labor and or rupture of membrane less than 34 weeks, you admit them and you give them the steroids. Development of preeclampsia, you think that, you know, they, or even someone you say, oh my God, she might be going, like this lady, headache, and the headache is not going away. She's 140 over 90 now. You think she might be going to preeclampsia very soon. You also, and she's less than 34 weeks, we would give her steroid because we may anticipate she may go to preeclampsia with severe feature, and then we have to deliver. Also, corticosteroid is not routinely administered to patients with non-severe gestational hypertension because preterm birth less than 34 weeks is uncommon. Like, so those who have gestational hypertension, we may not need to do this. Like, not everybody with gestational hypertension, you go ahead and give them steroids, no, unless they're at risk of preterm delivery. If delivery is indicated, like you have to do, if you have to do a medical induction of labor, a delivery is indicated, less than 34 weeks, corticosteroid is recommended. Delaying delivery for optimum steroid exposure may not always be advised. If there is a risk on mom or baby, you know, it is not advised. Maternal or fetal deterioration may prevent completion of the course of steroid treatment. These are the doses, and maybe you use the same or use different, but betamethasone, 2 times, you know, 12 milligram IM dose, or 4 times of 6 milligram IM dose. And also, this is like for late preterm gestation, which is 34 weeks to 36.6 weeks. It's controversial to give the betamethasone, even among faculty in my institution. Some of them will say give, some of them say no, you don't need to give. So it is still controversial. Again, more expectant management, more about that. So frequent testing, really, like we said, of blood pressure, labs, and monitoring the baby really can be modified. based on the stability of baby and mom. Once preeclampsia and proteinuria is diagnosed, additional quantification of proteinuria are no longer necessary. So we don't necessarily, once we diagnose you have proteinuria, in the past we used to do like, okay, every week we check to see how much is increasing. And we may like plan for a delivery if it's increasing higher, but now they do say you don't need to check it anymore because you are following other parameters to induce the lady or not, or induction of the pregnancy. Advise women to immediately report if they have any persistent concerning symptoms, progression to preeclampsia, and that's what you were saying, Alexandra. Progression to preeclampsia with severe feature, whether it's gestational hypertension and preeclampsia. For gestational hypertension, it may progress to preeclampsia with severe features within 1 to 3 weeks. But preeclampsia without severe feature may progress to preeclampsia with severe features within days. That's why this lady who came in with headache and blood pressure of 140/90, if her headache didn't go away and continue to have headache, I'm worried about this. I'm worried that, she will go within days to preeclampsia within severe features. So a little bit more on expected management of labor provides benefit. So waiting for a little bit, expected management and not going for induction can help neonatal benefits, to get the steroid in, to do maturation of the lung, but it's not advised when neonatal survival is not anticipated. Like if you think that baby's not going to survive, you don't need to wait. Also consider it in women with preeclampsia with severe features, less than 34 weeks gestation, when mother and fetus condition is stable. Even if she's on magnesium, you may benefit from a 48-hour to get that steroid in, because you want to have like a better, less morbidity or mortality for baby. So if she's stable, you have her in the hospital, you're watching her, you're checking blood pressure, she's on mag, we do, but I cannot really, you have to follow your guidelines in your hospital or policy in your hospital and your country. Previously, in the past, they used to say, oh, she has fetal growth restriction. It was considered an indication for delivery. But in the setting of normal parameters, meaning amniotic fluid is okay, Doppler finding, antenatal testing is reassuring, continuation of expectant management is reasonable in the absence of other risk factors, like mom and baby are both stable, even if it's a fetal growth restriction. During expectant management, delivery is recommended at any time in the case of deterioration of maternal or fetal conditions, and these are the conditions. Like uncontrolled severe range blood pressure, 160/110, persistent headache, refractory to treatment. So you give Tylenol, not getting better, and she's persisting to have it. Epigastric pain or right upper quadrant pain, unresponsive to repeat analgesics. Visual disturbance, motor deficit, altered sensorium, stroke, myocardial infarction, HELLP syndrome, new or worsening renal dysfunction, creatinine more than 1.1 or it doubling the baseline, pulmonary edema, eclampsia, suspected acute placenta abruption or vaginal bleeding in the absence of placenta previa. The other part is fetal deterioration, abnormal fetal testing, fetal demise, fetus without expectation for survival at the time of maternal diagnosis, like lethal anomaly, extreme prematurity, persistent reversed end-diastolic flow in the umbilical artery in the case of fetal growth restriction. I did mention that you can keep monitoring, but if there is a persistent reverse end-diastolic flow in the umbilical artery, that baby needs to be delivered. So now the case continues. Now the same lady that you've been monitoring, you have her in the hospital. She's the same 19-year-old, 33 weeks. You give her reporting headache and it's not better with Tylenol. Now having some vision change, she has some spots. She had one blood pressure of 160/105 4 hours ago, and you kept checking, but everything was still below then. And then suddenly now she have 170/110. Her fetal heart tracing is still good. Blood pressure is 140 beats over a minute. Urine protein creatinine ratio is 0.3, or you can say 2+ to 3+. Normal AST, ALT, and platelets. So what is the most likely diagnosis here? I will see if anybody would respond.
Let's see if there are some answers in the chat. So, what is the most likely diagnosis for this patient now with this criteria? So, again, several questions, several answers about simply preeclampsia. And what would be immediately next step? What would you say?
Yeah, so it is preeclampsia, but now it's preeclampsia with severe features. Alexandra, can you help me? What do you call preeclampsia? In the past, we used to say mild preeclampsia, severe preeclampsia. And for some reason, the Americans decided to make it complicated and say preeclampsia without severe features, which equal the mild preeclampsia, and preeclampsia with severe feature were equal in the past severe preeclampsia. What do you call it?
We also, and as still it is in international classification of diseases, like it is mild, moderate, or severe. We even have this moderate.
Okay, even you have moderate.
Yes.
So I think I just need to clarify. I'm going to go to the next slide and maybe it will help with a clarification. So this is severe features of preeclampsia. Anything, so we have elevated blood pressure, equal or more than 160, equal or more than 110 diastolic. We have elevated creatinine. This is the ranges, more than 1.1 or 2 times baseline. Hepatic dysfunction, new onset headache or visual changes, platelet less than 100, pulmonary edema. This is severe features, plus, proteinuria. Could be proteinuria or no proteinuria. This is severe features for us, we don't have moderate. We have even severe or we have mild. So I'm not sure your mild is equal to gestational hypertension. Your moderate is preeclampsia without the severe features, and the severe is preeclampsia with severe features. I really don't, I don't know. I'm sorry, I should have known your guidelines, but I don't know.
Even Dr. Bulatovic and I are now commenting, but even we could not maybe say what is the moderate in fact. So maybe.
Well, it is some kind of between the what you Americans call without the severe features. But I look at your criteria here for the pulmonary edema and platelet count below the 100. It is at us for very severe preeclampsia, what we say like this.
Yes. So I think why they made the change, it's really the management. So the management, so for the management, this is now severe, right? This patient was in triage. Now what I'm going to do, me and my resident, we're going to start putting orders, admission to the hospital. And while we're doing that, we always talk about teamwork. Now her pressure is 170/110. I am worried. I don't want her to have a stroke. I don't want her to have eclampsia. So then I'm working, asking the nurses, and so we have to multitask here. We have to do a multiple treatment. So first thing, you do 2 things at the same time. I think we need to think of seizure prophylaxis, and we need to lower her blood pressure as soon as we can. So I'm having one nurse please go get me the magnesium. The other nurse, please get me the medicine for the blood pressure. So who do we prophylax? Who do we give magnesium sulfate? We give magnesium sulfate with preeclampsia with severe features, which helps to prevent eclampsia prevent eclampsia seizure. Number needed to treat is 100, and helps to prevent placenta abruption. That's the other thing, is 100. Magnesium sulfate is more effective for preventing recurrent eclamptic seizure and decreased maternal mortality than using phenytoin, dilantin, or diazepam, Valium, or a combination of chloropromazine, promethazine, and mepridine demerol. So it is superior. It is the drug of choice. It is the more effective. Women with normal renal function do not require routine check-in of serum magnesium unless, they have symptoms of toxicity. But I tell you, we do sometimes check it, like every 6 hours or so. Magnesium toxicity can lead to respiratory paralysis, central nervous system depression, and cardiac arrest. If deep tendon reflexes are present, magnesium levels are rarely toxic. So this is how we administer the magnesium. Again, you can see they're saying severe preeclampsia or severe gestational hypertension. Severe. Anything turns to severe will need, because then that's it's severe preeclampsia. We don't give it for regular gestational hypertension or preeclampsia without severe feature, which we used to call mild preeclampsia. No longer, we don't give any magnesium anymore. So the loading dose is 4 to 6, it's in 100 cc of water, 5% dextrose or saline. You give it intravenously. It should take within 15 to 20 minutes, and then you do infusion continuously, 2 grams per hour. Monitor reflexes, mental status, respiratory status, and urine output. Monitor magnesium level. Therapeutic is 4 to 8. If patient has renal dysfunction, elevated creatinine, then urine output. And urine output, you start seeing the urine output going down, less than 30 ml per hour, loss of reflexes or other symptoms, we need to check magnesium. This is the management of magnesium toxicity. Discontinue magnesium is the first thing. First thing you want to do, stop that drip, Check serum magnesium level immediately and every 6 hours. Deep tendon reflexes are last to be lost. Respiratory rate less than 12 breaths per minute. Creatinine, and check in if creatinine elevated or urine output is less than 30. Overdose and maternal death have resulted from improper use of magnesium. Antidote for magnesium is 1 gram calcium gluconate IV administered over 2 minutes. Serum magnesium concentration, you lose patellar reflexes when it's more than 9, you have respiratory paralysis when it's more than 12, and you have cardiac arrest when it's more than 30. So now, we are now continuing with the management of preeclampsia with severe features. We said we're doing multitask here, multitask. First, we're getting the magnesium, but at the same time, I'm having to lower the blood pressure. So 2 nurses, one is going to get that, one is going to get the blood pressure medicine. And we need to lower it to prevent maternal end organ damage. Blood pressure is only mildly elevated in 30 to 60% of women with eclampsia. So regardless of the number, you need, when it's preeclampsia with severe features, because some women, even with mildly elevated pressures, they could go to eclampsia. Those with preeclampsia without severe features should be monitored closely, and magnesium should be started if severe features develop. So this again supports that we do not give magnesium. It's preeclampsia without severe features. They have to have severe features. even with gestational hypertension, we do not give it unless the gestational hypertension is now becoming preeclampsia with severe features. Fluid management, you got to be careful with fluid because excessive fluid can cause pulmonary edema and ascites. Too little fluid can exacerbate intravascular volume depletion and organ ischemia. We got to keep urine output. We monitor it more than 30 ml. And we put a Foley catheter so we can, we don't want to miscalculate the urine output, especially when she's on magnesium. Total IV fluid should be less than 100 ml per hour. If you give her by mouth, like for us, we give her maybe ice chips or, she can get some liquids, then a total should be IV and oral less than 125 ml per hour. Delivery planning, expediting delivery based on the disease severity and gestational age. Blood pressure management in women with preeclampsia with severe features. The optimal, yes.
Sorry for interrupting, but I don't know if other participants cannot see your slides at the moment.
Oh, so what do you want me to do? What do I do?
Maybe stop sharing and then share again.
Okay. Okay, where is the stop sharing? And I will
share again. Some of the, yes, great.
Okay. Excellent. And then let me just open the share again.
Yes. So some participants could see, but for example, in my window, we could not see.
Oh no, thank you for letting me know. We want everybody to see. Okay, great. Well, let me go to my slides. Sorry, the slides are long, but I thought it's a very rich subject.
I think this is in very fine details. I think it is very good, especially when they come back to your slides again after. Yes, now we can see everything. Thank you.
Wonderful. Thank you, Alexandra. Thank you. So the blood pressure here, the optimum blood pressure is unknown. They can't tell what is the best blood pressure you want to hurt the goal. Excessive lowering of blood pressure may lead to uteroplacental insufficiency. It is recommended that systolic blood pressure be less than 160 in this case and less than 110 to prevent stroke. For us, I put it in red. Check with your institution and country on the medicine of choice for you. For us, IV labetalol and hydralazine are commonly used in acute management. Sometimes we do oral nifedipine. Like, I asked the nurse, go and get that. But, she have to go. She have to take the name of the patient. The doctor need to put the order in. She have to go and get it from the Pyxis we call. It takes time. So sometimes we give oral nifedipine. It could be much quicker as an alternative if we think it's going to take time. At least we give her something. Particularly when urgent lowering blood pressure is needed and IV access has not been established. Again, that's another thing the nurse have to put, because we give it IV to lower it, and the nurse have to put an IV, and it could take time. So we do this first. Let's see. Okay, so antihypertensive agent, again, please follow with your guidelines and your hospital policy and what's available, but we give beta blocker, we give hydralazine, and we give a calcium channel blocker. And you see, first, we give it IV, we give it IV, and you have to give it in the timing. You don't want to do too fast or too slow, but you give it appropriately as it's asked, I think I'm not going to say more because of the difference of the medication between, in between countries. This is just a figure that I found. It's about who in severe preeclampsia with severe features, who are candidate for expectant management, who are not candidate. So those who are equal or more than 34 weeks, uncontrolled blood pressure, persistent symptom, and lab abnormality, we have to deliver. Those who have blood pressure able to control with oral agent, no persistent symptoms, no lab abnormalities, everything stable. You can wait, for at least fetal maturity and all that. Preeclampsia with severe features, so expectant management, same, you do antenatal testing. Now here you do daily, now this is severe features. You're not gonna let her go, right? You're gonna keep her, you're gonna check her NST daily. Like today I heard there was one lady, she had also elevated severe chronic hypertension, but not preeclampsia. They were doing NST 3 times a day. So really you modify what you do based on the need of the patient and the baby, the risk stratification. We also check amniotic fluid, periodic ultrasound to assess fetal growth. Data is limited about the expectant management between 24 and 34 weeks. Between 24 and 34 weeks, fetal lung maturity may be accelerated by giving steroids. So you may want to delay, if you can, delay it for 48 hours to give the steroids. If mother and fetus are stable, corticosteroids should be administered to women with preeclampsia and preterm labor and or rupture of membrane less than 34 weeks gestation. Also in hospital with prenatal and neonatal service, there is decrease in neonatal morbidity and if there is an ICU stay if you have a neonatologist and prenatologist. Many women are not candidate for expectant management and require urgent delivery. Again, they say you can watch, get the steroids, but many of these women, you cannot wait. They're still telling us, be careful. If you can't wait, you can't wait. But if you can't wait, at least give that steroid. Even a few hours of steroids can help. Like that's what I've seen here done. Like even if we can't wait, we give the steroids. Just we say a few hours of steroids can be helpful. Okay, next slide. Okay, so again, like I said, this is just like maybe a repetition, of, so delivery less than 24 hours. Who do you want to deliver? Delivery after initially stabilizing mother with resistant severe hypertension, eclampsia, pulmonary edema, abruption, maternal deterioration, fetal deterioration without waiting for 48 hours after steroids. These are the ones that you want to deliver. And I'll come to eclampsia. There's one more sentence that will come later about eclampsia and delivery. Delivery more than 48 hours. Delivery should occur with corticosteroid. If a patient with thrombocytopenia and it's stable, LFT 2 times limit of normal, fetal growth restriction, but the Dopplers is still good. There's no reversible, persistent reverse Dopplers, umbilical Dopplers pressure. Severe oligohydramnios, you still can wait, if everything is stable, umbilical artery reversed and diastolic flow, or new or worsening renal dysfunction. And you can still, if it's stable, but if it's not stable, you deliver. So how are we going to deliver? What do we choose? Do we choose a C-section or do we do the vaginal delivery? We should always attempt vaginal delivery if it's not contraindicated. Delivery route and timing are based on maternal factors, maternal disease progression, parity, cervical exam finding, fetal consideration, gestational age, antenatal testing results. Cesarean delivery indicated if there's recurrent Caesar refractory to medical management. And I will add this. Over here, the practice, the doctors are comfortable if she had 1 Caesar and she's stable and they think she had a favorable cervix and she's going to deliver, they're promising they will induce labor. They will not go directly for a C-section. But if she's not showing promise or progression, so she will be short, not necessarily short, but they will induce her and see if she's the progression with 1 Caesar and then now she's controlled. But if she have recurrent Caesar refractory to medical management, definitely considering cesarean delivery. Severely elevated blood pressure that is resistant to antihypertensive, maternal or fetal deterioration remote from delivery. Some experts recommend cesarean delivery in preeclampsia with severe feature, and an unfavorable cervix require delivery before 30 weeks gestation. And as you know, below 30 weeks, they need days and days sometimes of induction. Okay, now I'm going to talk about, there's a new trial, and we are kind of managing chronic hypertension in antenatal is a little differently. Chronic hypertension is associated with increased risk of preeclampsia, pulmonary edema, acute kidney injury, cardiomyopathy, stroke, medically induced preterm labor, placenta abruption, small for gestation, and maternal mortality and perinatal mortality. While there's a consensus, there is consensus supporting treatment of severe chronic hypertension in pregnancy to reduce the risk. Significant variation of international guidelines exist regarding the treatment of mild chronic hypertension, defined as blood pressure equal or more 140 and less than 160, diastolic more than 90 and less than 110. The result of recent published chronic hypertension and pregnancy CHAP trial, RCT, provide guidelines or guidance to implementation of study finding. In summary, when we had a patient that had blood pressure of 150 over maybe 100 or 150 over 90, chronic hypertension, we did not treat. We were waiting for the 160 over 110. This is no longer what we're doing. We are treating once it's hitting 140 over 90. So this is now, I'm sharing with you the guidelines that we have. So ACOG, American Academy of Obstetric Gynecology, recommend utilizing 140 over 90 as the threshold for initiation, starting, or titration of medical therapy if they're already been on a medicine for chronic hypertension in pregnancy, rather than the previously recommended threshold of 160 over 110. Continue the same antihypertensive medication that a woman is taking before pregnancy in the absence of side effect. Definitely, you don't want to choose an ACE inhibitor or an ARB. These are contraindicated, so you need to choose medication that is safe in pregnancy, and that if she is taking the medicine before pregnancy, you can continue the medicine in pregnancy if it's safe, or change it or switch it. The CHAP study did not establish a goal. So they didn't go, what is the goal of that blood pressure? So now you treat, you want to keep her like at 130, you want to keep her at 120. They didn't establish the goal, but they just said treat when it's 140 over 90. Don't wait to 160 over 90, treat at 140 over 90. It did not establish the blood pressure level below which growth restriction may be risk. CHAP study treatment did not increase the risk, so they did not. When they gave the patients in this study treatment for chronic hypertension at the level of 140 over 90 to lower it, they did not increase the risk of fetal growth restriction. But at the same time, they did not know what is the best blood pressure for the babies to not get growth restriction. The baseline risk of fetal, it did not increase the risk. The baseline risk in patient with chronic hypertension warranted. But if you have, the baseline risk of fetal growth restriction in patient with chronic hypertension warrants a third trimester ultrasound assessment. So what it means like if you have someone with risk factors for growth restriction, which chronic hypertension is a risk factor, being on medication could be another risk factor. We need to do assessment for fetal growth by ultrasound in the third trimester. What they do here, they do monthly after 28 weeks. They do monthly, fetal growth. They do more than that if they feel that the baby is not growing, by the anatomy scan. Also, the CHAP study protocol requires exclusion of preeclampsia by clinical diagnostic workup before escalation of medication, dose beyond 20 weeks gestation. And that what means, because chronic hypertension could progress to chronic hypertension with preeclampsia without severe feature, or chronic hypertension with preeclampsia with severe feature. So they said, before you go up on the medicine, make sure, do some lab work, make sure, is she complicated now with preeclampsia, or is she chronic hypertension becoming severe? Also, acute, severe, persistent elevation of blood pressure in the second half of pregnancy need further evaluation, observation period, because concern of superimposed preeclampsia. Again, these are the medication that we use orally. And I would say, please check with your institution, country, hospital, what do you do? But we do oral labetalol beta blocker, we do calcium channel blocker, methyl dopa. I've used methyl dopa. I come from Iraq and we use methyl dopa a lot. Hydralazine also, and prazosin, what is used. And you know, they all have their own side effects profile. So now we're going to continue the case. Same patient, you know, blood pressure is 170 on 110 and headache is not resolved by Tylenol. Now having some vision change, she sees spots, and suddenly her eyes, you see her eyes is rolling out, and she starts convulsing. So what is the likely diagnosis now? Anyone want to say, what is she having now? Yes, I can see that. Yes, eclampsia, definitely. Excellent, eclampsia, excellent, eclampsia. And our immediate step, we have a nice table for that to go over what we're gonna do. So it is eclampsia. So eclampsia, let's see, where is that? Okay, eclampsia is a life-threatening emergency and can occur in about 53% antepartum, intrapartum 19%, and postpartum 28%. Eclampsia less than 20 weeks gestation is rare in the absence of gestational trophoblastic disease, like, you know, molar pregnancy and so. Eclampsia may be preceded by CNS symptoms such as headache in 80% and visual change in 45%. However, Caesar can occur without severe features of preeclampsia and with a normal blood pressure. About 15% of women with eclampsia have a diastolic blood pressure of less than 90 millimeter mercury. Eclampsia Caesar are usually generalized and last about 60 to 90 seconds. Post-ictal confusion or agitation or combativeness may follow. During the eclamptic Caesar, the fetus often manifests hypoxia-related bradycardia, but usually recovers post-Caesar. And this is the table which almost have all what you need to do about this. So you may situational awareness, you know, ask for help, make sure, you know, patient is not going to fall. And if she's standing or, you know, make sure she's in a chair, she's not going to fall. Avoid polypharmacy. You want to choose magnesium. I wouldn't choose diazepam or phenytoin. Magnesium is the first choice and the gold standard here. Protect the airway. This is probably the first ABC, you know, airway, and this, make sure she's not like choking, because again, hypoxia could happen. If you have anything to help with that, the position of the patient. Also, they may vomit, so that can block the airway. You want to put her on her side. If you see she's vomiting, put her on her side. Prevent maternal injury, like I said, fall or fractures. Administer magnesium. This is, like we said, to control convulsions. And then follow delivery plan. Avoid the temptation to perform immediate cesarean delivery for a self-limited Caesar episode. If it's self-limited and it came better and you were able to control, you can try delivery, but if it's recurrent and you can't control it, definitely think. And follow your protocol in your hospital, follow what you guys, because you know the situation better in the monitoring, the nursing staff, the availability of things. This is what I'm sharing, what we may do, but you guys, you know the best, what is best for your patient in your countries and hospitals and what is available. Now we're going to continue the care. Some patients now, this patient is stable and she starts bleeding and blood is not clotting. Her platelet count is 35,000. Her fetal monitor starts showing decelerations and seems not to be tolerating labor. What is the most likely diagnosis? Yes, I can see. Wonderful. Thank you. HELLP syndrome. You are correct. You are correct. So we'll talk a little bit about HELLP syndrome. It occurs less than 1% of all pregnancies, pretty rare, but in 20% of pregnancy complicated by preeclampsia with severe features, we see the most in those who are with severe features. It may present in preterm, 53%, including 11% less than 27 weeks gestation, term 18%, or postpartum 30%. Diagnosis is challenging because symptoms can mimic those of other illness. Challenge in diagnosis for HELLP syndrome in the absence of classic preeclampsia symptoms is about 12 to 18% women with HELLP are normotensive and 13 do not have proteinuria. So it's really sometimes challenging. Atypical HELLP syndrome can be diagnosed without meeting the blood pressure criteria for preeclampsia. Evaluation includes CBC, LFT, a DIC workup like fibrinogen, prothrombin time, partial thromboplastin time should be ordered for women with abnormal bleeding or a platelet count less than 50 times 10^9 per liter. So this is the diagnostic criteria of HELLP syndrome in a graph table, or as you know, we mentioned it, AST, more than 2 times upper limit, hemolysis, LDH, increase. If you do peripheral smear, you see like damaged erythrocytes, schistocytes, birth cell, helmet cells. Bilirubin can go up from the hemolysis, and platelet count is less than 100 per 1003. So, well, how do we manage HELLP syndrome? So basically the management, women with HELLP syndrome should receive a MAG until 24 to 48 hours postpartum. A platelet transfusion is indicated if platelet is less than 20 before vaginal delivery and less than 50 before C-section. So we need a higher rate for C-section in women with abnormal bleeding. Or any woman, if she's like bleeding abnormally, you want to do the platelet. Also, those who have neuroaxial anesthesia is safe when platelet is more than 100, but should be avoided if the count is less than 50. Corticosteroid increase platelet count in women with HELLP syndrome, but they have not been shown to improve fetal or maternal outcome, except for the proven benefit on lung maturation, less than 34 weeks gestation. If we needed more medicine, we will give, and that includes if the patient is getting into more bleeding and DIC. We have to be, when we replace platelet and doing all that, we have to be aware of pulmonary edema. Again, this is antepartum. She could have preeclampsia with it. We're giving MAG for Caesar. We're treating the platelets, so be aware of pulmonary edema. Careful with fluids. Correct as necessary. Anemia, packed RBC, coagulopathy, FFP, thrombocytopenia, platelets, hyperfibrinogenemia with cryoprecipitate. Now the case continues. Now she's postpartum. This is the last section we're going to talk about. Postpartum. The nurse calls and tell you that your patient, 27-year-old, postpartum, day 1, after vaginal delivery, and her blood pressure is 140/98. You check her prenatal record and she did not have any elevated pressures during antenatal care. She had normal blood pressure during labor. What do you want to do next? You have a postpartum vaginal delivery, new onset, new blood pressure elevation. What do you want to do next? Or what do you want to do check on? What do you think of that, any of those? So postpartum elevated blood pressure has been always, yes, close monitoring, thank you, yes, close monitoring. You want to repeat that blood pressure. Again, you follow, now she's not pregnant, you follow kind of the, if she outside pregnancy, just like if she's not pregnant, but you keep in mind the preeclampsia with severe features, worsening chronic hypertension, they all can present in the postpartum. So let's talk about postpartum hypertension. And I really apologize about how busy the slide is, but I thought I felt like it's important for me to mention that, and you can have it to read it afterwards. So postpartum hypertension observed as many as 20% of patients within 6 weeks of delivery. So patient, when she come back, if she may not have elevated blood pressure then, but she may have it afterwards when she come for her postpartum check. Risk factors include high body mass index and history of diabetes mellitus and other etiologic factors. So what is this elevated blood pressure? It could be persistence of antepartum or intrapartum hypertension. This patient did not have it. This patient have a new onset postpartum hypertension. Sometimes women may have what we call transient. It means temporary new onset postpartum hypertension. And this can be due to the increased volume of intravenous fluids when we do C-section or we're giving her multiple, like they keep giving fluid IV and she's taking Pitocin and she's taking fluid, many things happening. Or they had neuroaxial anesthesia for labor and added fluid. They may have that transient new onset postpartum hypertension. Or the loss of pregnancy associated vasodilation after delivery. Pregnancy is a vasoconstricted status, but they have here loss of pregnancy associated vasodilation after delivery. There's mobilization of extravascular fluid after delivery to the intravasculature. If we give a ergot derivative, so Bethergen, for prevention or treatment of postpartum hemorrhage, and or we have prolonged administration of high doses of non-steroidal NSAIDs. We give ibuprofen for pain, high doses for analgesia. All this can be a reason why we have the transient or temporary new onset postpartum hypertension. Saying that, it's important to recognize postpartum preeclampsia. It is often associated with persistent headache and or visual change. So for those women who have elevated blood pressure, what is the next step? I need to go and number one, observe them, just like Dr. Pujic said, Borislava Pujic, thank you, and hello, Dr. Borislava. We have to do close monitoring. The other thing, I'll go bedside and ask her, do you have any headache? So I examine the patient and then try to define, is this just transient hypertension, or since she didn't, this lady, the example we gave, the case did not have it in her labor delivery. But if it was during labor delivery and antepartum, it's a continuation, could be chronic hypertension, gestational hypertension. But if she didn't have it, is it transient or is it preeclampsia? So then I go and ask her question and examine her. So don't forget about postpartum preeclampsia. The other thing, aldosteronism is rare cause of postpartum hypertension. Typically, there is decreased blood pressure during pregnancy due to the natriuretic effect of progesterone, and they may present with postpartum hypertension with or without hypokalemia with this situation. So Patient with new onset like this patient should be evaluated by history, including review postpartum medication and fluid balance. Did she have too much fluid intake? Did she have a lot of ibuprofen or any other thing? Do an examination, do some lab tests, liver chemistry, platelet count, creatinine, urine protein. I know they say urine protein, but really, you know, when they have vaginal and they want to pee for us, unless it's from the catheter, you know, unless she had a Foley catheter, guess what? She's going to pee and some blood will going to be there and there's contaminated. So, you know, about the urine protein, I'm not sure. This is from the resource I got, but when I think about it, you know, they have to be CAFUA. Abnormal findings, neurological, cardiac, or gastrointestinal symptoms, lab abnormalities suggest disorder other than rule out transient hypertension related to fluids and or medication. In approximately 5% preeclampsia cases, sign and symptoms are first recognized postpartum. So preeclampsia, 5% of them will be in postpartum. First recognized postpartum, like a postpartum preeclampsia, usually within the 48 hours after delivery, but it could be more than that. I have seen patients come in after a week with preeclampsia. So how do you manage postpartum hypertension? A new onset with lab abnormality consistent with preeclampsia, treat mother, blood pressure, close monitoring, and magnesium to prevent convulsions. Patient with postpartum onset of preeclampsia. Some patients are diagnosed with preeclampsia for the first time after giving birth. Administer magnesium. With those with new onset, non-severe hypertension, with headache and blurred vision, or those with severe hypertension with or without the signs of preeclampsia with severe features. Antihypertensive therapy is administered to patients with severe hypertension to prevent stroke. Magnesium sulfate is usually continued empirically for 24 hours. We may extend the duration of if patient is not improving clinically within 24 hours. So magnesium, you can do it 2 days. You can do more than 1 day if you think they're not getting better clinically. Or some of the doctors have done 12 hours. I've seen this. If they say, oh, she's improving clinically, she feels better, headache are gone, they may do 12 hours. I've seen that. But most of the providers here will do 24 hours at least. Also diuresis, you want to keep her urine output more than 100 ml per hour for 2 consecutive hours. Resolution of symptoms, headache, visual change, epigastric pain, all is gone, and resolution of severe hypertension. These are when you can do maybe 12 hours. This is to support the 12 hours. You have to have all these, diuresis, resolution of symptoms, you know, she's getting better, all that. So more about the management. Now we talked about the magnesium, but now we're going to talk about the hypertension. So especially acute, and if severe hypertension, especially acute and associated with symptoms, headache, chest pain, shortness of breath, require treatment within short period of time. Don't delay because you worry about stroke. So within 30 to 60 minutes, you got to get that treatment in. Given the risk of peripartum stroke, lower blood pressure with intravenous and oral medicine for these patients. Again, we do labetalol, hydralazine, and calcium channel blocker. So you do what you do in your hospital. For non-severe, you know, those who are less than 160, less than 110, most pregnancy-related strokes occur in the first 10 days postpartum and typically within 48 hours postpartum, with hypertension the strongest risk factor. It is suggested to treat antihypertensive therapy for patients with systolic blood pressure more than 140 and diastolic more than 90. That persists when the patient is ready to be discharged, just like Dr. Borislava Pujic was saying like we observe. So if she had 2 at least of these numbers, we need to give her medicine before discharge. And they keep, sometimes they keep these patients for 3 days, honestly, to get them absolute control. So treatment, use antihypertensive, I'm sorry, the slide is busy. This was a last minute. Use antihypertensive medication like those used for maintenance therapy in pregnancy. So the same thing, you know, you can use the same, the safe, because now she's breastfeeding. So you want to make sure that you use safe medication, and you may want to consult with neonatology if you need more than one medicine. Also, one guideline suggests avoiding methyl-dopa postpartum because of the risk of postnatal depression. And really, I thank you, Alexandra, for having me prepare this, because, you know, there's more data and we learn more. So I learned this while preparing this lecture, that methyl-dopa can cause postpartum depression. And also high quality evidence guide, optimum management postpartum non-severe hypertension is limited. We don't have enough data to say what is the, okay, I give her medicine, what do I tell her the normal is? But I would say you treat her as if you're treating a chronic hypertension. As a family physician, I treat them with pregnancy and when they're not pregnant, like pregnant or not pregnant, I treat. So the goal is less than 140/90. So, and a brief, sometimes they give furosemide, which is a diuretic in therapy. Sorry. They give 20 milligram orally once or twice per day for about 5 days. This to reduce the time until resolution of postpartum hypertension plus severe edema in women who have swelling edema, severe edema, and they have hypertension postpartum. A trial of furosemide. I don't think there's enough data, but it's been practiced, and it will. They use it only when there is severe edema, or maybe edema related to use of ibuprofen NSAIDs. So it's not studied extensively. Again, what is the target blood pressure? Due to the increased risk of adverse cardiovascular outcome in patient with history of hypertension disorder, treat and maintain blood pressure equal or less. You want it less than 140, less than 90. In patient with antihypertensive therapy, blood pressure systolic 140 or diastolic 90 in the 12th hour before discharge were associated with 3-fold increased risk of readmission because of a hypertensive complication in one study. So you want them below this number at discharge, because like this study showed, you have, you know, a patient coming back for complication from hypertension in the first early postpartum. If history of new diagnosis of chronic hypertension, the blood pressure goal is same as that of a non-pregnant. Like I said, I treat the postpartum like non-pregnant patient with the same goal, less than 140/90. I think we're coming almost to we have like 2 more slides. So follow-up. So these patients, I will have them follow up in 3 days after discharge, especially those with severe hypertension during pregnancy or postpartum period. They have high blood pressure, come back in 3 days. But I can do 7 days for those who didn't have the severe feature or didn't have highly elevated blood pressures. Advise women about alarm symptoms. Again, still preeclampsia is common, stroke is common. I had one lady stroked at 7 days. We've had a couple of patients come back for severe preeclampsia. So we tell them headache, vision change, shortness of breath, chest pain, upper belly pain, please come back to the hospital. Also, we can offer them blood pressure monitor at home. Sometimes we discharge them, it comes to their room. There is now a study about that. One of the, I think, residents in OB is doing a study, handing a blood pressure monitor just to see compliance, you know, and accuracy. Discontinue antihypertensive therapy. When do we feel comfortable to stop it? I think in Serbia, maybe, and other countries, that will be maybe the job of the internist or the general physician or the family physician, whatever, you know, you have. But it's good to know you actually bring them back. if she's having lower blood pressure, you can start tapering it off. Like I had a patient, I gave her Procardia 60. And she came and her blood pressure was beautiful. It was like 120/80. So I went from 60 to 30 and have her come back in a week or have her check her blood pressure at work and tell me. If she's still below, I take the blood pressure medicine away. I said, stop the blood pressure medicine, check your blood pressure off the medicine and let me know. Really, so it's really slowly tapering and stopping if the dose can be tapered. And long-term prognosis. So these patients have risk of heart disease, risk of chronic hypertension, and you want to make sure that they get into yearly checking their blood pressure. If their blood pressure go back to normal, yearly check their blood pressure, make sure they're, active, exercise, weight is good, BMI is good, and following to check, on their cholesterol at least once a year if needed. And last slide is prevention. So prevention of preeclampsia. I know we talked about doses. I think me and Alexandra were chatting about doses. You have a different dose for prevention than we do. Our studies in the United States was based on the 81 milligram of aspirin. So low dose of aspirin 80 has a small to moderate effect on prevention of preeclampsia. Number needed to treat is 72. The effect is greatest. Number needed to treat 19 in women at highest risk for developing preeclampsia. So the American College of Obstetrics and Gynecology recommend low dose aspirin starting at 12 weeks gestation for women with a previous delivery less than 37 weeks gestation due to preeclampsia or in more than one previous pregnancy. Had preeclampsia. The U.S. Preventive Task Force, which is another guideline for us, suggests low-dose aspirin use with multi-fetal pregnant, twin, triplets, all multi-fetal gestation, chronic hypertension, type 1 or type 2 diabetes, mellitus, renal disease, autoimmune disease, or several moderate risk factors. US also criteria would, by using the USPS criteria, this will decrease the rate of preeclampsia from 4.18% to 3.83%. The treatment of 23.5% of women compared to the decrease of from 4.17 through treatment of 0.35 in women with ACOG criteria. So it's a little higher rate of improvement. Calcium is another thing. If calcium supplementation may prevent hypertension, preeclampsia, and maternal death in high-risk women with low calcium intake. It's rare in developed countries. These are the references, and I would say thank you. I don't know where's my thank you. I'm sorry, I don't think. Oh, here's thank you. Thank you very much.
Shala, this was wonderful. Really, and if you were
it was very useful clinically, yes.
If you were very careful, then you will also know how to answer the final quiz questions.
Yeah.